Are we live now?
Yes. Yes.
So, a very good evening to one and all. Today, I'd like to welcome you all to the second episode of our Cataract series. The topic for today's presentation is IOL calculation formulae and IOL calculation in special scenarios. I'm Dr. Deertha Parekh, and as told by Sir, I'll be coordinating today's session and all the upcoming sessions of the series. So, on the panel, we have Dr. Mathew Kurain. He has done his MBBS from CMC Vellore and his post graduation from St. John's Medical College, Bangalore. Sir has also been an assessor with NABH, and he has also worked as a medical superintendent and head of cataract services at Narayana Netralaya, Bangalore. And currently, he's the medical superintendent and head of cataract at Chaithanya Eye Hospital, Kochi. We have with us Dr. Vaishali. Ma'am is a consultant at Raghudeep Eye Hospital. She has more than 25 peer-reviewed publications to her credit, and she has also made several scientific presentations at various national and international conferences, and has also given many faculty talks. The moderator for today's session is Dr. Neeraj Shah. Sir is the Chief Medical Officer and consultant of cataract and cornea services at Sankara Eye Hospital, Jaipur. The presenter for today's session is Dr. Sneha Kukreja. She is currently pursuing her IOL fellowship from Sankara Eye Hospital, Jaipur. Over to you, Dr. Sneha. Please present your PPT.
Good evening, everyone. I'll just share my screen. Yes, can I start? Can I start?
Yes, please go ahead.
So today's topic is IOL formulae in special scenarios. Fyodorov was the first one to devise the formula to predict the IOL power. He devised the formula with three parameters: and axial length, the keratometry, and the anterior chamber depth. This was when ACIOLs were being used. The formula particularly stressed upon the position where the IOL is resting. This position is called as the ELP, or the effective lens position. It's basically the effective distance between the anterior surface of the cornea and the lens plane, assuming that the lens is infinitely thin. This ELP is a main limiting factor for postoperative refractive predictability. So over the years, this predictability has been the predictability has been improving using different formulae. Starting with regression formulae. These are basically mathematical and statistical analysis of many post-operative results. These were seen in first generation and second generation formulae. The first one was SRK formula, which worked well for regular eyes, but did not work for longer short eyes. Then came the second generation formulae, which were modified Bincost and SRK2 formulae. These also had some residual refractive error. So then came the Vergence formulae. So the earlier ones only used the mathematical and statistical data, but did not involve any optics of the eye. These Vergence formulae were based on the Gaussian optics. These formulas applied two additional simplifications. That is, they combined the anterior and posterior corneal surfaces into one surface, and they approximated the IOL as a thin lens. These included the third generation and the fourth generation formulae. Now, these third generation formulae were the SRKT, Holaday 1, and Offer Q formula. These are, since they included ACD, they were better for short or long eyes. They were fair, but they still needed some refinement. Then came the fourth generation formulae, which was Haig's Holaday 2, Barrett Universal 2 formulae. These were again, Holaday 2 had 7 variables, so included much more parameters, and so they were much more refined. Barrett Universal Tool, which is quite accurate in all ranges of axial length. Then came the ray tracing formulae. So this was based on the principle that the individual rays passing through different diffracting surfaces being traced. It calculates the postoperative lens position as a fraction of crystalline lens thickness and anterior chamber depth. It allows the formulation to take corneal and IOL higher order aberrations into account, thus improving the accuracy. So these included the Olsen formula, and then we also have the FACO optics, which is an IOL, which is an online calculator. This Olsen formula was based on studying axial and paraxial light through the eye with particular the lens. It used C constant, which was dependent on position of the lens, the anterior chamber depth, and the lens thickness. Then came the artificial intelligence based formulae. So these basically combined all the data to give us much more accurate results. The first one being Hill RBF calculator. It combined AI with the regression analysis formulae that we seen earlier. It is an advanced self-validating method for IOL power selection, employing pattern recognition and data interpolation. It was optimized for use with biometric data from the Lenstar LS900 optical biometer in combination with the Alcon biconvex lens of the particular model. So the best results are seen with this combination in Hill RBF calculator. So this is how the online RBF calculator looks like. You need to enter the data, the axial length, the CCT, the anterior chamber depth, and lens thickness, along with the keratometry values and the white to white. So, yes. Okay. Next, we have the Kane. Kane combines AI with theoretical optics. The Kane formula, again, this is how the online calculator looks like. You need to enter the specific data, axial length, keratometry, and the anterior chamber depth. And accordingly, it calculates calculates using different IOL formulae. If you have the lens thickness and CCT, it again uses a particular formulae and gives the results. So you have different IOL types, around 14 IOL types in this. If you any of those are not available here, you can just enter the A constant for the required IOL formulae. Then we have the LADA super formula, which automatically chooses the most appropriate formula according to the axial length and keratometry. It included formulae SRKT, Hofer Q, Holaday 1, Holaday with Van Gogh adjustment, and Haig's formulae. Then we have the Pearl DGS formula. Pearl stands for Prediction Enhanced by Artificial Intelligence and Output Linearization, and the DGNS was named after the formula developers. The Pearl formula is based on thick length equation and uses machine learning models to predict the posterior corneal radius and theoretical internal lens position. So this is how the Pearl DGS online calculator looks like. You have three different options: regular eyes, the complex eyes, which involves post-myopic laser vision correction, post-hyperopic laser vision correction, post-RK, post-ICL, and any non-physiologic cornea like keratoconus. And also for second eyes, basically performing other eye surgeries, which will give more accurate results based on the refraction seen post-operatively. So for regular life, this is how you need to enter the data: axial length, the keratometry, and the anterior chamber depth, and with particular A constant and the IOL model and the target diffraction that is there. Again, for complex eyes, you can enter the pre-LASIK data available or pre-ICL data available, and in case of keratoconus, the other values can be entered. Next, you have the EVO calculator, the emetropia verifying optical formula. It's an advanced intraocular lens formula for cataract surgery. It is based on the theory of emetropization and generates emetropia factor for each eye. Again, it's a thick lens formula. It takes into account the optical dimensions of the eye. Okay, again, same how it looks like, and you can enter the pre-LASIK and post-LASIK data that is available. Coming to the special scenarios, we have we first see the variations of the normal anatomy. This is the Holaday schema of the eye. Basically, it divides the eye into 9 different classification, and this gave a better judgment about which formulas to be used, and depending on the different parameters, the axial length and the anterior segment size. So in case of short eyes, the main challenge or the main problem is that the up to the third generation formulas, it assumes that because the axial length is short, the anterior chamber depth is also shallow, and so the predictability of the effective lens position is varied. So that's why we have the newer formulas that can be better used in this case. So in case if the axial length is less than 22 mm, but you do not have the anterior chamber depth measured, then you can use a Hoffer-Q formula. And if you have the anterior chamber depth measured and the axial length is less than 20 mm, your Kane formula, EVO are better than Hagius-Holladay 2 and Hoffer-Q formula that can be used. And if the axial length is more than 20 mm, both conventional and newer formula give good results. In case of long eyes, if the axial length is again more than 26 mm, in so you can use Barrett Universal 2, which is better than Hill RBF or Olsen formula, but target should be up to 0.5 diopter myopia. And if you are using Haigis SRKT formula, target should be at least 0.5 to 1 diopter myopia. If the axial length is more than 30 mm, again target should be up to 0.5 diopter myopia if you're using Barrett Universal 2 or Hill RBF formulae or Haigis with optimized constants. And target should be 1 to 2 diopter myopia if you're using Haigis formulae. Next, we have pediatric eyes, which is a challenge because there will be growth of the eye, and so there will be elongation of the eyeball and the changing corneal curvature, which gives a myopic shift. So in this case, depending on different parameters, that is if the patient is amblyopic, if there is bilateral cataract or unilateral cataract, or what is the how much is the compliance about the treatment of the patient in the future. Depending on that, we give either undercorrection or full correction. So if there is undercorrection, the hyperopia should be corrected immediately, and at a later age, the patient will eventually become emetropic. And if you are giving full correction, immediately there is emetropia, and in the later age, the patient may have myopia, which can be corrected at late eventually. But in both the cases, treatment of amblyopia is a must. If you are undercorrecting, how much this should be the undercorrection? So many studies have been done. Dahan and Brusdo, they suggest that in less than 2 years, 20% undercorrection should be done, and in 2 to 8 years, 10% undercorrection should be done. And Prost gave further that 1 to 2 years, 20% undercorrection should be done, and in 2 to 4 years, 15%, 4 to 8 years, 10% undercorrection can be done. NAD formula gave the rule of 7, which can be easily applied in most of the cases also. So their newer this thing is the pediatric IOL calculator, which is available online. It's basically a computer program that uses Holladay 1 algorithm. It has a pediatric normative data for the different keratometry and the axial length values. It calculates the immediate postoperative pseudophakic refraction and in the immediate period, and as well as at the later age as the child grows. So different iatrogenic situations that we will be seeing is the aphakia, post-refractive surgery, post-keratoplasty surgery, and silicone oil filled eye. Coming to aphakia, usually IOL calculation is required for secondary IOL implantation. Between immersion and contact, immersion technique is a method of choice, but all the optical present biometers, aphakic mode is available, which gives much accurate results. So in older times, Makul's formula was being used, which was more accurate. But when ACIOL were implanted, and then there were other formulas also for PCIOL, but the more accurate ones are being that are being used is either immersion technique or the optical biometers with aphakic mode. Next, we have the post-keratoplasty surgery. Standard methods of IOL power calculation are inadequate because of different factors that are altered. That is the anterior corneal curvature or the ratio of the anterior and posterior corneal curvature and the corneal asphericity. Modern formulas use these factors to calculate the IOL power. As we see in myopic LASIK and RK, there is flattening of the central curvature, and in hyperopic LASIK, there is steepening of the central curvature, because of which there is overestimation or underestimation in the keratometry values. So basic challenge is that anterior and posterior curvature ratio changes, because of which there is flattening or steepening of the K, and which underestimates the IOL power and gives hyperopic surprise eventually. So all the Vergence formulae is what will underestimate the ELP and thus give a hyperopic surprise. So there are various methods being designed to eventually overcome these challenges. If you can either use historical data completely using the clinical history method or Fees-Manis method or corneal bypass method, or you can use historical data along with post-operative K values. If you're using both pre or post-op K values, you have your Arambari double K method and Barrett 2K method, which are good. And if you're using if you're using refractive correction, then you have again different formulae based on adjusted refractive index and adjusted corneal power, that includes Sharma's diffraction derived method, and adjusted IOL power, which includes Maskett and modified Maskett methods. And if there is no historical data, then you have your refraction based methods, which is your contact lens method, Maku's method, and intraoperative wavefront aberrometer. If so, the post-op K can again be used from devices measuring anterior corneal curvature and both anterior and posterior corneal curvature. So the devices that give only the anterior corneal curvature can be used in modified Maloney's method, Van Kock Maloney method, Sharma's PL, Haigis L, and Barrett 2K methods. If you're using post-op K can be calculated from again devices based on OCT and swab source OCT. And then you also have much more better values that can be calculated using the ray tracing methods, which gives you the true corneal power as in pentacam, or EKR values in pentacam. Again, true corneal power values again in Galilee, on Oculix or Fico optics. These data can be used directly in different formulas. So these are the EKR values seen, and you can use up to 1 to 4 data that is there and can be added into different formulae. So these are the true corneal power values that is taken up in different formulae. Okay. Next we have the ASCRS calculator, that is American Society of Cataract and Refractive Surgery online calculator. It's a website available which has 3 modules: myopic LASIK or PRK, hyperopic LASIK or PRK, and RK. It gives 14 different methods, and different formula are incorporated. Double K, Holaday 1, Sharma's PL, Haigis cell, and OCT based, and Barrett 2K formula. Maskett and modified Maskett methods directly provide the corrected IOL power, and it also gives the maximum, minimum, and average IOL power using all methods, in addition to the power calculated by the individual methods. So this is how the website looks like. You can choose from the 3 different categories, and enter the pre-LASIK data, LASIK or PRK data if available, and you can again enter the post-LASIK data, that is if topography is done. You can enter those values to corneal power values, or you can enter the Atlas ring values, that is the EKR values, in different zones. Next, you also enter the biometric data, that is the keratometry values, axial length, and the A constant. When you can calculate, and it gives the calculation in different formulae with different formulae. So coming to post-keratoplasty, full thickness and anterior lamellar keratoplasty. If you're doing simultaneous keratoplasty and cataract, standard keratometry can be used, that is 43.5, or you can use contralateral keratometry of the other eye. Mean K value that can be derived from surgeon's past keratoplasties can also be used. There is always a tendency for postoperative hyperopia, so the target diffraction should be made accordingly, and any of the new generation formula are good. Cataract surgery following keratoplasty, complete suture removal is advised so that the refractive error is stabilized. Axial length can be measured with optical biometry, and keratometry, corneal topography is preferred. Tendency for myopic shift post DAL. So good predictability with Kane, EVO, Hopper QST, and SRKT formula. See. In case of endothelial keratoplasty, there is a hyperopic shift. Good refractive outcomes are seen with newer generation formula. Barrett Universal 2, EVO 2.0, Haggis, Hoffer Q, Holiday 1, Kane, and SRKT formula. In case of silicone oil-filled eyes, a major challenge is the sound velocity, which is much slower. So it takes longer time to reach the retina, and thus the ultrasonic axial length is falsely high in presence of silicone oil. To overcome this, you have different conversion factors that can be used, which were used previously. But we have the other options that we have nowadays are the introp. Either you can have introp measurement of the axial length after silicone oil removal, or you can do intraoperative aphakic refraction. Fellow eye axial length can be chosen, but it's difficult in case of an isometropia or one-eyed patients. Pre-vitrectomy axial length can be used, but again, in case of RD or buccal surgery, it's difficult. Optical biometers in silicone oil mode can be used and have increased accuracy. Next, we have the pathological conditions, that is a keratoconus. The challenges that we have is the altered anterior and posterior curvature ratio, which again is difficult to be taken by the automated keratometers, uh, because of which again there will be inaccurate effective lens position, because there is steepening of the cornea, which will falsely detect higher axial length and deep anterior chamber depth. So the K values, optical biometers, they again overestimate the K values and underestimate the IOL power. Pentacam thus is most appropriate in case of keratoconus and other pathological conditions. So in case of mild and mild to moderate keratoconus with K values less than 55 diopter, the actual K values can be used in the formulae. And in case of advanced keratoconus with K values more than 55 diopter, standard K values of 43.5 diopter can be used and have proven to give better results. Since there is always postoperative hyperopia in these cases, it's always better to have some target post-op myopia with K values less than 48 diopter, -1 diopter gives good results. And with K values less than 55 diopter, -1.5 diopter gives good results. And with K values more than 55 diopter, -1.8 diopter has proven to give good results. Which IOL formulae to be used? Some studies suggest that SRK2 is better than SRK and SRKT formulae. Other studies show that SRKT has the least error, whereas some studies say that Barrett Universal 2 has the least error. So any of these formulae can be used. We also have the KC formulae, that is Kane KC, Barrett 2 KC, and Holaday 2 with KC adjustments. Kane KC is a theoretical modification to the original Kane formula using a modified corneal power derived from the measured anterior K values and reducing the influence of corneal power on ELB prediction. Barrett true K KC is the modification of the post-refractive true K formula using the measured posterior cornea. Kane KC has divided or classified keratoconus severity into 3 stages. Stage 1 with less than equal to 48 diopter, stage 2 with more than 48 diopter, stage 3 with more than 53 diopter. And according to these stages, he has recommended different adjustments to the refractive target that can be made in case of K-conus patient. So in case of stage 1, no adjustment required. Stage 2, 0.75 to 1.5 diopter. In stage 3, -2 to -3 diopter refractive target gives good result. Among the most of these formulae, 2K KC has given good results with post-op refractive error within -1 diopter. So other than that, even Kane KC has given good results. So Barrett 2K KC, Kane KC are both freely available online. This just summarizes the different IOL formulas that are seen or can be used in different, that are available in different biometers. Thank you.
Thank you, Dr. Sneha. That was quite an elaborate presentation. I'd like to request our faculty members for their opinions and any additional points.
Dr. Mathew.
Yeah, hi. Can you hear me?
Hello. Yes, please.
Yes, thank you for having me over here. So basically what all the formulae are doing is trying to estimate the effective lens position better. And the winner will be the one that is doing this job the most accurately. So even now the jury is out, I would say. And because it is available with several of the devices, we don't have to do transcription into a website. The Barrett Universal 2 and the Barrett True K are the most commonly used, I would say. In terms of measurement error, I think we have reached sort of frontier threshold limit in terms of the accuracy of measurement that we can do. And in very small eyes, a small measurement error results in a large refractive surprise, whereas that kind of errors, the same magnitude of error in a very long 30-35 millimeter eye is going to result in negligible refractive errors. With regard to pathological corneas, irregular corneas, either iatrogenic or pathologic, we had published a couple of years back a paper in which we looked at the Holaday EKR, and using that we had derived a coefficient of variation. And when the coefficient of variation is above a certain cutoff, we had considered doing ablation of the surface to make the surface more regular, to eliminate the irregularity. So we are not bothered about altering the refractive error at any point. we were looking at making the surface more regular and then wait for a couple of months, 4 to 6 weeks typically, by which time the altered cornea reaches a steady state. So we measured steady state by saying that three measurements at 1 weekly intervals should be equal. And then you go ahead and do your IOL power calculation, do the cataract surgery, and the result was much better. If you try to customize the cornea or alter the shape of the cornea after the IOL is inside, you end up with a refractive error. So preoperatively customizing was in our thought process the better option, and now it has reached a sort of good consensus amongst many other places also. Challenge in individuals with keratoconus is that the cornea is like a multifocal cornea, especially if it is a decentered cone. And looking at EKR alone, you may get a very different value above the midline and a very steep cornea below the midline or infranasally, where the peak of the cone is. And in these individuals, when we had attempted to do ICLs and other form of refractive correction, it worked well if we were putting a single segment, pushing the cone more to the center of the eye, centralize the cone, then you will have you will still have a multifocal cornea, but it will all be in the same visual axis. Otherwise, you have one visual axis below the crystalline lens visual axis separately. And then these eyes did better with intact segment, which would push the cone centrally. I think with these thoughts, I would close my thing and hand over to Vaishali.
Thank you so much for having me here, and very nice to see Matthew sir here as well. So I think a lot has been covered by Dr. Mathew, and I think I just have 2 or 3 very simpler points. The number one, because I understand that a lot of us attending this webinar are starting off their journey in cataract and refractive surgery. So the number one determinant of any formula or any calculation is the measurements that you take. So I think we all focus so much on the formulae and Barrett and this and that, but in an average eye, and particularly in a short and a long eye, usually what I have seen is that sometimes the measurement is the one that is the error, and then the formula gets the flack for it, or the surgeon gets the flack for it. So if you don't have access to an automated biometer like an OCT or an optical biometer, even there, but particularly in ultrasound biometry, you must look at the spikes, the actual printout. Don't go on your calculation, one page which has the calculation. Look at the actual results and the quality of a single spike and then tapering spikes and all those things that we know. One is that. Second thing is the corneal measurements, which are often marred because of a dry eye or an untreated surface, which makes it very irregular. So either don't put any drops before you make these measurements, but if the drops have dilating drops or IOP drops have been put, please lubricate the eyes, put in twice at 10 minutes intervals, and then wait for half an hour and then do these measurements. So I think is very crucial, and I keep seeing it time and again, even with the new biometers, you have to look at they give you these warning signals, yellow mark or an asterisk or a star based on the machine that you are using. So if you see anything like that, please repeat. The second thing I thought is there is so much information, and really I must congratulate you, Dr. Sneha, for this extremely comprehensive presentation. While I was going through it this evening before we sat down, there is so much information even for somebody who does it day in and day out. It can become very confusing and overwhelming. So if I really have to say, in a standard case, within a good range, post LASIK or a short eye, long eye, regular case, I would, if I have to say 1, 2, 3, what is your go-to formula? Today for me, it is still the Barrett Universal 2. You could use the online APS-CRS version, which is the latest, or you could use it on your device if it has. Having said that, two other formulas that I am very excited about today are the Cane and the Evo. So I think this is what my preference or my order of choice would be in any kind of eye. Yeah, so that is some two things I wanted to highlight. And then third is these pediatric eyes, because I have a special interest in small eyes, and we have published some studies also. I think there the problem is more of the proportion of dimensions, but more importantly, the ocular growth. So it's all very nice to say that you leave the child emetropic and they will become myopic, or you leave them hyperopic and they will become emetropic. But there is a huge variation in the way the eye grows. So I think that is one field where we still don't have many answers. And uh, again, most of the new formulae, all the fourth, fifth generation, the AI based, they're all made for optical or OCT biometry. So I think in pediatric eyes, any formula is as good or as bad as the other, provided you have good readings on your handheld keratometry if it's a young child and your ultrasound biometry. So yeah, thanks.
Yeah, true. Dr. Mathew,
Yep.
would you like to make any comments on, obviously everyone would be interested about AI. So AI formulae and what is the current status?
So Hill RBF was the one where I have maximum experience with. And it's the good thing about all these AI formulae is it is continuously evolving. The more data you feed in, the better the models get and the more predictable they get. And in 2018-19, as I was leaving Narayanetralaya to come to Kochi, actually we had some conversation with them, and they were looking to improve their data sets on axial lengths more than 30, and they had very few. So for these extremely long or short eyes, they would give where their data was not good enough to give a good outcome, they would give out of bounds. And the more interesting thing was it would also recommend what was the formula that Warren Hill himself would suggest in in those kind of situations. So it would be like, go for the Lada super formula, or you go for the Barrett formula or something like that, where their own data is led. But now in the past 6 years, those data sets have improved a lot. So the out of bounds thing has become much more infrequent, I would say.
I think if I can also add to this, Neeraj, you rightly pointed out that AI is going to be AI and ray tracing. These are the two methods we are all looking forward to. And in fact, if you see the last 3-4 months publications, studies have started coming up. For example, one where the Zeiss has an AI IOL calculator. And when they looked at, compared it with the Barrett Universal 2 and I think another Cane or something, the AI one did really well in short eyes, and again in same way in long eyes. So that is the way to go. But I feel that still the kind of, particularly the Hill RBF, I mean, that was the first thing before most of us even knew what is AI. And at that time we would say that this is a neural network based formula. So it unfortunately, because of, like Sneha had pointed out, the limitations in the data you could enter, the IOL models available, it didn't really pick up as much as it should have. But we still are not today at that point where we can say that in particular XYZ AI formula is better than the other theoretical ones.
Obviously, it will all depend. Obviously, AI, when we talk about AI, it all depends on the data set and how hygienic is that data. So it will improve over time.
With regard to the ASCRS calculator, it gives you the minimum, it gives you the average of whatever formula is there, and it gives you the maximum. In a prior myopic eye, Vaishali, what are your thoughts? Which would you choose and why?
So that's a great question, because you have minimum, maximum, and average, and sometimes the variation is up to a diopter. So in fact, we have looked at post-myopic LASIK eyes and post-myopic RK eyes and compared all these values on the ASCRS calculator itself. And we found that in myopic eyes, the least variation was found when you, myopic LASIK eyes, sorry, when you use the minimum formula. So use the minimum power available on the from the values you get for a post LASIK eye. But for a post RK eye, because there are more variations, the average value gave us a little better prediction. So that is what right now we do.
What about hyperopic eyes?
So hyperopic eyes, again, we don't have enough data of post hyperopic LASIK eyes. But again, we would, if there is a large variation, we would go for an average. But typically, we try to aim for minimum for that also.
For the sake of our audience, would you want to kindly elaborate on the thick lens, thin lens concept on which these formulas are designed?
Vaishali?
Probably might.
So I must admit that I really am not a very big expert on understanding the way these work, the thick and the thin lens formula. But basically, what I understand is that in a thick, there's an equation which the lens maker uses, and in thick in if you put a thick lens in an air, what would be the focal length of that lens is how the formula calculates. So, but if you really ask me to explain the physics of it, I am not an expert, so please excuse me.
It would be way beyond this session. Dr. Mathew, you were saying something.
Yeah. So the thin lens formula makes more number of assumptions. The thicker lens formula has less number of assumptions. So it is desirable to move slowly towards thicker lens formulae, and that is what most of the newer formulae are doing. And Olsen and all not only look at the central rays of light, but also at the paraxial rays of light. And they are supposed to give this kind of slight better outcomes with regard to special situation eyes. So I think the tendency.
Thick lens formula, from what I again, I'm not 100% correct, but what I understand is that the thin, like Sir said, thin lens formula assumes a particular thickness of the lens, and all these newer ones, which are thick lens formula, actually measure the lens thickness, and they will be, titrate the thickness of that lens, and therefore their assumption, the equation is a little more complex. If you see, they use more variables, and therefore their calculations are better.
So there is one very interesting observation that Dr. Vaishali, Dr. Mathew, both of you all made. So in the previous session, we were talking about biometers and the principles and everything. So Dr. J.K. Reddy was the chairperson of that session. So we had touched upon the topic of ELP, effective lens position. And in his opinion, as of today, uh, we've reached the maximum accuracy possible in terms of prediction for ELP, which is what determines a lot of, the post-operative outcomes. So that is what you people were also saying, that in terms of calculation, in terms of measurement, sorry, what I meant was measurement. In terms of measurements, we've reached a good amount of accuracy. All depends on how accurately you measure them, but the fundamentally we are able to measure them quite accurately. What is your opinion on ELPs?
So last year or year before last, I had done a study where we had taken 5 intraocular lenses models. Three were Indian IOLs. Two of them were the very basic lenses, supraphobe and the acrifold, hydrophilic, hydrophobic, which we are using for our CAM cases. Then one was the mid-segment Indian lens, which is the Auroview. Then we had two of the foreign lenses, all monofocals, all single-piece models, the Technis and the IQ. So in those, we had actually measured the post-operative refractive outcome and the ELP. And HOLADE has given a formula for calculating the ELP. So based on that, I had, with the raw data available, calculated the ELP and looked at the achieved ELP. Now, the lenses that gave the most accurate value in terms of post-operative refractive outcomes closest to plano, which was the targeted IOL power in all situations, were lenses where the ELP actually varies. So I had used only normal eyes, 22 millimeters to 26 millimeters with white to white of 11 millimeters to 13 millimeters. So this is in the HOLADE schema, the central one, normal by normal axial length by normal anterior segment dimensions. And even in that, the lens ELP, actual achieved lens position, goes up and down. And because it is more, I would say, sensitive to the geometry of the bag and the anterior chamber and the rest of the geometry of the eye, these were giving the best targeted refraction. There were other lenses which, irrespective of the axial length, anterior segment geometry, etc., would give a very deep position in the achieved lens position, whereas the calculated ELP is supposed to be very different. So those eyes always had a hyperopic result. So the lens geometry actually makes a lot of difference. So you can do the best formula, but then depending on the lens you use, if that lens is not sensitive to variations within the anterior chamber of the eye, within the bag, then it is going to give you refractive surprises. So that study was a good learning experience for me as well, because I had assumed that calculation accuracy and the the formula you use would give consistent results. But after that, you have to choose the lens, and the lens also should be responsive to the changes within the eye.
I think so. That's a great point. And I mean, like sir said, what IOL you use, and particularly when we are using now these more and more aspheric ones with aberration treated, a lot of categories of EDOF. Sometimes what happens, that a little decentration or a tilt will actually, it's causing a higher order aberration, but when you measure, so it will be measured as a cylinder or a little bit of a sphere. So it's actually a higher order, fourth or fifth order aberration manifesting as a lower order aberration. So it may not be a true myopia or a true astigmatism, but a little bit of that HOA. So I think with these newer lenses, with so much precision required, even in the bag, they can't move either this way or that way. That can also, like sir said, very much affect what you are going to end up with.
So, Dr. Mathew, could you please again repeat? You were saying that in that study, some lenses were responsive and some were not. So, what did you exactly mean by that?
So, let us say we are looking at axial lengths between 22 and 26 millimeters only. And assume that these eyes are proportional, okay? Because we are looking at normal anterior chamber length. So the equator of the 22 millimeter, equator of the lens of the 22 millimeter eyeball is going to be slightly more anterior. And these are all plano lenses in the sense that, they are flat, they are not angulated posteriorly or anything like that. So if there is no zonular dialysis, no intraoperative events, etc., the IOL will sit exactly at the equator. And in a 22 millimeter eye, the equator should be slightly more anterior. And in a 26 millimeter eye, it will be slightly more posterior, right? Now, if you have a lens which, irrespective of 22 or 26 millimeter axial length, is always going to sit, the optic is going to sit at the back at say 5 millimeters or 5.5 millimeters, then the likelihood is that it will give a hyperopic, the deeper it sits, it will give a hyperopic shift. The more shallower it sits, the more likelihood of a myopic refraction. Now, in a 22 millimeter, the calculation says that it should be slightly more anterior, and in a 26 millimeter, it should be slightly deeper. So within the so-called normal eyes also, the ELP is varying. And depending on how close to the calculated ELP, the achieved ELP of the IOL model is, then you are able to get target refraction. Now, you can use the same information to do your IOL customization also, the A constant customization. So now, if you find that there is a particular one where the calculated ELP is 0.3 diopters deeper than the achieved one, okay, which means the myopic shift is there, then all you need to do is to alter it by that 0.3 diopters. Okay, sorry, 0.3 millimeters will be 1 diopter of shift approximately, or vice versa. Now, there will be lenses where there is a huge amount of variation. The mean is not close to zero. There is huge variation between the highest maximum and the lowest negative side. So you cannot customize those things by, irrespective of shifting the A constant up or down, you are just ending up with shifting the error. The range remains large. You are looking for eyes where the range is very small, and then you can shift the error and make it closer to zero. Do I make myself clear?
Yeah. Interesting. So routinely, so it's common, like you'll probably be encountering post-refractive. Then what other kind of cases and what formulas are your choice?
The go-to formula for me is the Barrett Universal 2. Post LASIK, I do both the Barrett True K and because it is there on my biometer, and I also take the EKR on the Pentacam and use that information on the ASCRS Formulae. And I tend to choose the average value because in a prior myope, I would rather have the person little bit myopic rather than hyperopic, because then when I do the first eye, I can always tell him that, see, this is the eye which I have calculated for your near vision. You are going to do monovision, and a little bit of a white lie helps me to get.
True. That is one interesting thing I wanted to ask Dr. Vaishali. Even I choose the average value, and you were saying you chose the minimum one.
Yeah.
So what has your experience been?
Yeah, so we published this study 2 years back in the British Journal of Ophthalmology. So that's what we would also normally do. Like you said, that average is a more safer looking value. But now that, like sir said, the measurements are getting better, the formula are getting better, even the laser vision corrections that we are seeing now are much better than really old ones. So we looked at the data and we looked at the mean absolute error of refraction. So what we were aiming for and what we actually ended up with. So, and we found that when using the ASCRS post-refractive calculator, where we had no prior history, and then whatever formulae are available, if you use the minimum for post-myopic LASIK, you were actually a little tighter. That means you were closer to what you expected compared to average. But in most cases, if you really ask me these days, with good centered ablations, you don't see a large variation. Up to half a diopter is usually what you see, minimum, maximum. Very rarely you will have like a 2 diopter range, even when the calculator gives you the output.
A challenge that I see nowadays is post-pterygium eyes. Because if you have a large pterygium on one side and it's been shaved off a little more deep, you'll have 44, 45 on one side. Then on the other side, you'll have very sharp step. It's like a gutter almost on the other side, like a hyperopic on ablation on the other side. So there again, I tend to look very carefully at the EKR values, and I do a little bit of adjustment there, and like try to correct half to 3/4 of the astigmatism that is present at the 4 millimeter zone. I would rather undercorrect rather than overshoot these individuals. So the aim is to reduce the astigmatism that is induced by the prior surgery rather than to completely eliminate it.
So interesting point there for pterygium. You're absolutely right what you said. We've noticed a couple of we've done a few cases here as well as in Coimbatore with Dr. J.K. Reddy. So it's common. We do find sometimes patients with pterygium with a lot of remnant pterygiums, and they actually lead to a lot of irregular astigmatism. So what we proceed in those cases is that we first remove all these remnants, regularize the cornea, wait for maybe 6 to 8 weeks minimum. Can wait up to 3 months, and once the K values settle down, there is usually a significant change in the K values, and with that, we are able to give much better outcomes. It can be very tricky to convince these patients that why they need to wait and that this intervention is very tricky to make the patient explain without burning the first surgeon, original surgeon. But it does a great deal of good for the patient.
Yeah, I agree. I think, like you said, I mean, telling the patient that you had come for a cataract, but sorry, I want to do your pterygium and then I'm going to do another surgery. So, in
Not even
today's
pterygium, some
environment,
sort of cleanup.
I mean, whatever, but yeah, I mean, in today's environment, it's often seen as a, money make. It can be seen as that. But
True.
the other thing, like Sir said, that a lot of them will have irregular astigmatism or varying. In some zone, it is better than the other. So, taking a mesopic pupil size, knowing what their pupil size is and what kind of astigmatism it is in that zone, gives more confidence. And if it's irregular, even in their mesopic pupil, whatever you do, probably we don't end up with good results because mainly of the aberrations.
I mean, yeah, true. And what about any experience with post-keratoplasty, post-keratoconus eyes? I mean, post-keratoconic eyes.
Like
What?
Dr. Mathew
How do
said,
you
I
guys
think
proceed?
we do the Barrett keratoconus. And today, I think the Kane and Barrett, these two keratoconus formulae are supposed to be the best. We only have experience in a couple of eyes, so can't comment much. But it depends on the centration and the regularity of the cone. If they are okay, if the, again, mesopic pupil has a regular astigmatism, they will behave much better. Otherwise, it's a challenge.
True.
We published a couple of articles in IGO and the JCRS on ICL after keratoconus. And in central cones, it is pretty much simple because the optical zone of the cone, the optical zone of the ICL when it sits there, and behind that, the crystalline lens optical zone, all of them are sort of more or less in the same axis. Okay, it may not be perfect, but it's more or less in the same axis. But in eyes where there is a eccentric cone, then you will have the cornea giving one optical axis, the crystalline lens giving a different optical axis, and any correction in the form of a phakic IOL would give the third axis. So in those eyes, you have to do something to centralize the cone. So doing a segment, push the cone centrally, cross-link it and fix that there, and then subsequently go ahead with the phakic IOL maybe 3-6 months later. That seemed to work well. But of late, I think people are a little more conservative in this management and probably do a primary PK in very severe eccentric cones and then go with whatever subsequent correction is maybe. Even I don't think Dr. Rohit at Narayan Nitrale is doing too many of the intax segments anymore.
So now the new thing is not exactly new, but now the trend is towards tissue addition, keratoplasties, and using actual donor cornea tissues. At the same time, other implants are also being worked upon. So that is going to be something very exciting. Anyways, we are at the end of our session. Your final closing comments, sir?
Um, I think the winner is going to be the one where there is the best accuracy in ELP prediction. Today, all the refractive surprise in routine as well as challenging cataract cases is ELP surprises. And right now, the reason why we have multiple options is just because all of them are slightly better in certain situations, but nobody is a clear winner. As time goes by, probably it will be a AI-driven model, which will give us the best predictable, most accurate ELP. And whoever wins the ELP race will win the formula race.
Formula race. Dr. Vaishali?
I think totally agree with sir. Only one thing, along with the ELP, the user friendliness and the ease of availability, where we are not dependent on going on to another calculator page and entering all the data. So any formula like the Barrett has taken up so well because it is so easily incorporated in our daily lives and free to access. So I think that is also going to be a major determinant. It is, and it will remain a major determinant of what is still used by daily people in every practice.
Yes, absolutely true. So interesting chat. Thank you, Dr. Mathew. Thank you, Dr. Vaishali. We'll close for the day. And hopefully you can join us for future sessions as well. Thank you.
Delighted. Thank you very much.
Thank you,
Vaishali.
everyone.
Bye-bye.
With this, we'll call it a wrap. And thanks a lot for your valuable participation. I would like you all to be a part of all the upcoming sessions as well. Thanks a lot.
Welcome. Thank you.
Good
Thank you,
job,
Neeraj.
Dr. Sneha.
Yeah.
Bye, Neeraj.
Thank you, sir.
Thank you.